Say goodbye to overwhelming textbooks and hello to vibrant interconnected mind maps. We welcome you to our new series of videos where we pick each mind map from our mind map bundle and help you run through all the important points you need to remember for your exams. You can browse our app while watching this video and download the mind maps for enhanced retention. So, let's get started. In this mind map, we'll revise some concepts related to dental caries. The theories of dental caries can be categorized into early theories, endogenous theories, and exogenous theories. Among the early theories, there was a legendary belief in the existence of a worm causing decay. Endogenous theories include the humoral theory. Exogenous theories consist of the chemical or acid theory, the parasitic or septic theory, and Miller's chemico-parasitic or acidogenic theory, which is the most widely accepted. Miller's theory states that dental decay is a chemico-parasitic process involving the decalcification of hard tissue followed by the dissolution of the softened residue. Additionally, there is the proteolytic theory by Gottlieb, which highlights the role of organic components of the tooth in providing a pathway for microorganisms through the enamel. The proteolysis chelation theory by Schatz and Martin suggests that keratinolytic microorganisms break down proteins and keratin, leading to the formation of substances that form soluble chelates with the tooth's mineralized component, causing enamel decalcification. Lastly, there are theories such as the autoimmune theory. The Newbron tetrad and Keyes triad are concepts that help explain the etiology of dental caries. The Keyes triad focuses on three key elements: the presence of a cariogenic microorganism, a susceptible tooth surface, and a diet that provides fermentable carbohydrates. When these three factors come together, it creates an environment conducive to the formation of dental caries. Newbron added the fourth factor in this: time. These factors work together to promote the development of caries. The DMFT or Decayed Missing Filled Teeth Index, developed by Henry Klein, Carol Palmer, and Knudsen in 1938, is the dental index used to assess the prevalence and severity of dental caries. The index follows several principles and rules. Firstly, no tooth should be counted more than once. Decayed, missing, and filled teeth should be recorded separately. The D component includes restorations with recurrent decay. The M component includes teeth missing specifically due to caries, including badly decayed teeth recommended for extraction. Teeth missing for reasons such as being unerupted, lost due to accidents, congenitally missing, or extracted for orthodontic purposes are not counted as missing. A tooth with multiple restorations is still counted as one tooth. Deciduous teeth are not included in the index. A tooth is considered to have erupted when its occlusal surface is completely exposed, and it is considered present even if the crown has been destroyed, leaving only the roots. The WHO made modifications to the index in 1987 and 1999-7. In the 1987 modification, all third molars are included. Temporary restorations are considered as decayed, and initial lesions like chalky spots are not counted as decayed. The M component still includes teeth missing due to caries only. The 1997 modification states that for individuals over 30 years old, the M component should include teeth missing due to caries or other reasons. For individuals under 30 years old, the M component should only include teeth missing due to caries. The index is typically assessed using a mouth mirror and a WHO probe. The Decayed Missing Filled Surfaces Index, developed by Henry Klein, Carol Palmer, and Knudsen in 1938, is a dental index used to assess the prevalence of coronal caries on individual tooth surfaces. This index is considered more sensitive and is often the preferred choice in clinical trials, evaluating the effectiveness of caries-preventing agents. Unlike the DMFT index, which assesses the status of entire teeth, the DMFS index focuses specifically on the surfaces of teeth that are decayed, missing, or filled. The DEF index, significant caries index, and root caries index can be revised here as given in our mind map. The next path, dietary studies, encompassed several research investigations conducted to explore the relationship between diet and dental caries. The most important one to remember is the Vipe-Home study, described by Gustafsson et al. In 1954 and summarized by Davies in 1955. Examined 436 adult inmates of Vipe-Home Hospital in Sweden, categorizing them into 7 groups based on their diets. The study concluded that an increase in sugar consumption, particularly in forms that adhere to tooth surfaces, and when consumed between meals, significantly increased caries activity. Additionally, the rapid increase in caries activity upon withdrawal of sugar-rich foods was observed. The Hopewood House study conducted by Harris and Sullivan from 1942 to 1967 focused on children aged 7 to 14 years in an institution with a diet low in meat and refined carbohydrates. Despite poor oral hygiene, the study demonstrated a reduction in dental caries through a carbohydrate-restricted diet. You can quickly revise other studies such as the Turku sugar study, Tristan da Cunha study, and the Newbrin study from our mind map. Coming to caries activity tests, the Lactobacillus colony count test is the oldest and most widely used reference test for assessing new caries activity. This test estimates the number of acidogenic and aciduric bacteria present in a patient's saliva by counting the colonies that grow on tomato peptone agar plates with a pH of 5 after inoculation. It is a highly sensitive test that can detect changes in diet and is strongly influenced by the intake of dietary carbohydrates, reflecting the amount of bacterial substrate and indicating an acidic environment. The test results are expressed as the number of lactobacillus colonies per milliliter of saliva with corresponding symbolic designations to indicate the degree of caries activity. A count of 0 to 1000 colonies is indicative of little or no activity. 1000 to 5000 colonies suggest slight activity. 5000 to 10,000 colonies indicates moderate activity, and more than 10,000 colonies represents marked activity. The Snyder test is a method used to measure the ability of salivary microorganisms to produce organic acids from a carbohydrate medium. This test utilizes a glucose agar medium containing the indicator dye bromocresol green, which undergoes a color change from green to yellow within the pH range of 5.4 to 3.8. The test is observed at 24 hours, 48 hours, and 72 hours. If the medium turns yellow at any of these time points, it indicates marked caries susceptibility. If the medium remains green, further incubation and observation are needed at 48 hours or 72 hours. If the medium remains green even after additional incubation, it suggests caries inactivity. The swab test is a method used to assess caries activity in young children without collecting saliva. It operates on the same principle as the Snyder test, which measures the ability of oral microorganisms to produce organic acids from a carbohydrate medium. Instead of collecting saliva, a swab is used to obtain a sample from the oral cavity. The pH of the sample is then analyzed to determine the caries activity. The interpretation of the test results is as follows. A pH equal or less than 4.1 indicates marked caries activity. pH 4.2 to 4.4 indicates active caries activity. pH 4.5 to 4.6 suggests slight caries activity, and pH above 4.6 indicates caries inactivity. The Albens test is a simplified substitute for Snyder's test. It uses less agar than Snyder's test. The salivary reductase test is designed to assess the activity of the reductase enzyme found in salivary bacteria. This test utilizes a dye called diazoresorcinol to indicate the level of enzyme activity. The interpretation of the test results is based on the color observed and the time it takes for the color change to occur. After 15 minutes, if the dye turns blue, it suggests a non-conducive environment for caries. If the color is orchid after 15 minutes, it indicates a slightly conducive environment. A red color at 15 minutes suggests moderate caries activity. However, if the color turns red immediately, it indicates a highly conducive environment for caries. Lastly, a pink or white color immediately after the test signifies an extremely conducive environment for caries. The Streptococcus mutant screening test is designed to estimate the number of Streptococcus mutans bacteria in mixed paraffin-stimulated saliva when cultured in MSB agar. This test was specifically designed for use in a large number of school children and is a simplified and practical method suitable for field studies. Some other key points related to dental caries including Stefan's curve, karyogram, caries vaccine, and some important dyes used in detection of caries activity. You can go through these points in this section of our mind map. Hopefully, we have helped you quickly revise dental caries. Good luck!